First, I'm going to introduce our moderator, Mr. Bradley Finegood, who I've had the extreme honor to work with the last few years. He is currently a strategic advisor, at Public Health Seattle and King County, and previously was an administrator with our Behavioral Health and Recovery Division. And I think he still is one of the co-chairs of our King County Opioid Task Force. And I'll just say what I really enjoy about working with Brad is that he gets stuff done. That's my favorite. So I'm going to turn it over to Brad.
Thank you, Caleb. And I can't believe you called me Brad Lee. That's like hashtag awkward right there. So I get the privilege of moderating the next two panels. So joining me for this panel on addressing mental health needs are two colleagues and really heroes of mine in this field that I've gotten to know pretty well over the last 5 years. David Newman, who's sitting beside me, has been working with drug users for over 30 years. He runs the outpatient drug and alcohol service program for a community psychiatric clinic. Also, he's the project manager for 3 low-barrier MAT sites, co-located at syringe exchanges. Currently, he's completing his MSW at University of Southern California, so if he has to leave to get on a plane, he's got class in the morning. No, and is focusing on engaging and treating people who use drugs who struggle with disruptive mental health symptoms. David is also super well known in my shop for leaving voicemails with, "Hey, I got an idea. Do you want to fund it?" And every single one of his ideas has really turned into really just amazing services for the people who need it most. And sitting next to David is Dr. Paul Grekin. Dr. Grekin works at Evergreen Treatment Services. He's an addiction psychiatrist and the medical director there of the opiate treatment program, and the outgoing medical director of Seattle Counseling Services, a community mental health center and SUD treatment agency for the LGBT community. Dr. Grekin is a clinical professor here at UW in the Department of Psychiatry. He has served as study physician on several clinical trials and as a medical peer reviewer for the Washington State Department of Behavioral Health and Recovery. And like David is to me, Dr. Grekin often gets weird, harebrained emails from me about ideas that I have that usually are a little too harebrained to come to fruition. So we're just gonna open up the panel here. I'm gonna start off with a couple of questions for our panel members. If you have questions, we're happy to take your questions as we go, but we also have time at the end. So to both of you, the question: how is meth use presenting among your clients with co-occurring mental health disorders?
To me, and I speak as a therapist and who has some active contact with folks, not only from a program standpoint, what I see is that there are a lot of people who are injecting amphetamine, and in fact, at the exchange where I'm usually at this time, the University District Exchange, most of the majority of the 2 million plus syringes that are exchanged on an annual basis and have been for the last 2 or 3 years are for meth users. What I see is folks are not just meth users, they use other drugs as their settings change. So I think it's important to know that meth use is not just a mono drug obsession, that people use different drugs in different settings. And I'll talk about a couple cases. In particular with co-occurring people, one of the things that I've found for people who are depressed or anxious is that, especially if they live in tent encampments, they tend to use meth in an adaptive way to maintain some sense of vigilance, because you can't always 100% know who you're sleeping next to or whose tent you're next to. And so, and it's an adaptive choice that works for a while for folks, but then what I often find is If there are underlying circumstances, and I'll talk about two different cases in a bit, if we get to it, but feel free to ask questions, because your questions probably be more exciting than what I had to say. But what I was going to say is that that these underlying issues that come up, so for example, fear, hostility, underlying trauma, and some of these clients have had a history of bad things happening to them where they should have been protected as youth, but their parents failed to do that, or society didn't look at them the way because of maybe their sexual orientation or some other reason. So those underlying issues, even if they've gone to meth for social reasons or for this maintaining vigilance, eventually those become expressed, right? And at least that's the hypothesis that I work on. When I talked to one of the folks I was going to talk about, when I eventually talked to his grandparents, they said, this is a great kid. He's 20 years old now. But when he became, up till, he was a normal kid, did well in school until he was about 8 or 9, and then something changed in how he related to others. He became withdrawn, could only relate to animals. And that person later, after trauma and then after getting access to a lot of meth, then you begin to see an expression of symptoms that are, it's unusual behavior in public. And I'll talk about what some of those behaviors are. I think, unlike the stereotype of people with co-occurring disorders, including stimulant use disorder, methamphetamine type, where people become aggressive, I don't usually see that. Which doesn't mean it doesn't happen, I just don't see it. I just often see people who have unusual behaviors in public that draw attention to themselves, like going into a post office not too far from here and saying the government is a conspiracy really, really loud. And so that will draw police attention because it's a federally protected site. And so that's what I see in terms of presentation. There is a move to get meth users to move from injection use to smoking as an attempt to see if some of those behaviors become less or expressed less often. I can say that some meth users do adapt to that. Every day at the nearby needle exchange, they give out 50 meth pipes. Those are usually gone within 30 minutes. And most of those are not repeat customers. So there are ongoing studies, surveys of a qualitative type to say whether that's effective or not. But who knows? That could be an effective way of changing some of what we see the end result is of long-term meth use.
Thanks, David.
Thanks.
Dr. Grekin?
So the way methamphetamine use presents at the two clinics I work at is quite differently. Seattle Counseling Service, which caters to the LGBT community, the methamphetamine use is most often men who have sex with men, and it's heavily tied to sex. This perception or experience that it enhances sex is a major factor in trying to assist people in quitting. It's often a deterrent because it's this belief that sex is never going to be good again, or I'm going to have to give up sex. And as we all know, going into recovery from any substance is often a lonely experience because you're giving up a lot of your social contacts. And if you're giving up sex along with that, or if you believe that you have to do that, that can often be yet an enhancement of this sense of loneliness. And in addition to that, having sex or desiring sex can be a trigger for people when they are in recovery to relapse. One of the most common things that we see in presentation is psychosis. That's often an impetus to bring people into treatment because it's a very distressing experience whether or not they know that the psychosis is due to the methamphetamine. People will also come in just because they're not enjoying this activity anymore that they can't stop, or they'll come in because there's pressure, financial, family, social, legal. So an example of a case that Seattle Counseling Service is a middle-aged man with HIV who has paranoia, using methamphetamine and believing that people are keeping secrets and laughing at him. There's no clear history that we have that his paranoia has ever existed separate from meth use, but we don't really know. He's also prescribed long-term opiates and benzodiazepines related to his consequences of his HIV disease, and recently was faced with eviction, but was actually able to beat this in court because it was shown to be a case of discrimination. But one of the unfortunate consequences of that is that just became more material for his paranoia. And recently, his therapist, when talking about this case with me, related that she had attempted some psychoeducation with him about methamphetamine potentially causing paranoia, and that has unfortunately resulted in her now being another target of his paranoia. At Evergreen Treatment Services, an opioid treatment program, everybody there obviously has opioid use disorder, and the presentation's quite different. So people are using methamphetamine with their heroin. We have clinics in 4 different cities, and the presentation is different there in different cities. When we opened the Olympia Clinic, Ron Jackson can probably tell the exact day. I don't really remember. I think it was about 15 to 20 years ago. One of the first things we noticed was that there's a lot more methamphetamine use down there. Up here it was predominantly cocaine. Methamphetamine use in the opiate users was pretty uncommon, whereas down there it was the reverse. And that the use of methamphetamine has not changed that much, at least in the last 4 or 5 years. But in Seattle, by contrast, we've probably seen a 50% bump in methamphetamine use in the last 4 years amongst our patients. And patients are telling their medical providers that they often don't have to pay for it. It just comes as a freebie with their heroin. They're, at least in the Seattle clinic, they're often homeless, the meth users, which fits with this description that David mentioned and other people have talked about today, that meth can serve as a useful tool when you're homeless to protect yourself and your stuff. Another observation about patients in the opioid treatment program is that trauma has a very high frequency in that population to start with, and I think that it's even higher in those who are methamphetamine users. Patient from that program that I might use by way of example is a middle-aged woman who suffered sexual and physical abuse as a child, and she's had severe physical abuse as an adult. She has diagnoses of PTSD, major depression, and probably ADHD. It's hard to sort out with that kind of history. And she started using meth and oral opiates, or at least stimulants and opiates, in her early teens. But was injecting methamphetamine started using methamphetamine in her late teens, but when she started injecting it in her 30s, that's when her drug use really spun out of control. And even though she's been able to remain in treatment with us for the last 8 years, she has had really pretty limited periods of abstinence from illicit substance use and remains largely unstably housed, bouncing between family, abusive boyfriends, or motels.
Thank you. We got about 10 minutes left. If we have any questions, just a question from my standpoint. I'm going to sort of jump to be an audience member for a second. And in my role, sort of in a policy role, what are any glaring gaps that you see in the treatment system that would help both of you as treatment providers and clinicians be able to do a better job of treating people who are using methamphetamine?
Yeah, do you mind if I, so one thing I'm going to say, and I'm going to speak as just a person who's done this work for a long time, not as a policy thing for CPC, so I just want to differentiate that. I think that we really don't do well for housing here. This is not surprising, but I think we have great pilot projects for Housing First, but they're not fully enhanced the way they're supposed to be, where there's 24-hour access to behavioral health and interventions available for people on a menu that they can just pick at will, which is how it's done in Ohio and how it's done in San Francisco and New York, and we can find countless examples that are published and evidence-based. So if, because many of the folks that I have worked with, I'm thinking of another case where luckily, even though he had an embattled position with his mom, he was able to, as he was willing to explore some of the voices he heard and engage in some psychiatry and take Suboxone, he was willing to sit down long enough for some cognitive behavioral therapy to work. And he said, well, all these things that he thinks his mom's doing to him psychically, he was willing to put aside for a month or two and live on his mom's couch until there was this like epiphany that all that stuff was just stuff rattling around in his head. But there's plenty of people who are willing to make changes and want to, but they don't have a safe place to be. And they really, we would need a housing first model that is universal. We need to put aside all this housing readiness stuff, which makes people who answer phones, and I hate to say this because you're going to be mad, but I'm going to say all those nice people who answer phones and scale people, and they score them one way this year, and they're going to score them differently next year based on the epidemic du jour. That needs to just be gone. You just need to say, oh, you want a place to live. Here's a place to live. Here's a social worker. You could call her at midnight if you're scared. That's what it really should be, and it should be universal around this county, not just here, which is lovely, what we do here, but also East King County, South King County. So that's my soapbox.
I'm glad at least that they're nice on the phone.
They are very nice.
Paul?
I think the gaps are not specific to methamphetamine necessarily. So in substance use treatment programs, both OTPs and other substance use treatment programs, the way the WACs are written, you have to provide services by chemical dependency counselors. And, chemical dependency counseling helps some people, and it probably helps people most who are at a stage in their recovery that they're ready to learn these tools. But generally, when people first come into treatment, what they really need is more case management services, certainly access to things like housing, but also assistance with other things such as getting adequate medical care, food, help dealing with their legal problems. And the way the structure is set up around funding for these programs, that's not really reimbursable service. I would say that that's probably the biggest impediment to effective treatment, and programs that are able to do that usually are doing it through various kinds of grant funding, and we'll actually hear more later today about some of those programs, and I think those are really the smartest way to address people when they first come into treatment.
Thanks. I was having a conversation with a colleague earlier when we were talking about contingency management. And I think one of the things about contingency management is that it doesn't take a licensed professional to implement contingency management. There's, some type of paraprofessional or peer or some other types of folks. We know that we're also in a workforce shortage too, and with professionals. I think we have time for probably one question for our panel, if anybody has any questions. Yeah.
I heard loneliness mentioned, and I guess that kind of got my interest just because loneliness has been talked about as sort of the silent killer for a lot of different things, and it's emerging a lot in the literature. And I don't know if that's also, it was just mentioned though, I don't know if you view that as maybe the root of a lot of the other things that you were describing, but I wonder whether or not it is, one, but then two, whether or not it's something that has impacted how you approach their treatment. Because, at least as far as I know, there's no like treatment for loneliness, but it seems to be this critical thing that keeps coming up.
I guess I'm not prepared to identify roots, but I do think that loneliness is a factor both in the maintenance of addiction as well as making it hard for people to sustain recovery. And I think that that is why for many people, self-help groups, which are primarily 12-step groups, are very helpful. And why for those people, it's a good thing for them to be involved in it. Unfortunately, that format, there's a lot of people who just don't click with that, and so they can't make use of it. And for those other people, at least through counseling, we'll often try to either possibly find a group, but I think even better is to find the more meaningful activity in the community around others. So it could be some kind of volunteer work, church, if church is something for them, or even a job if they're prepared for that, but some way to connect with other people in a structured way.
It was mentioned earlier by one of the speakers that how important connection is. And if you've ever read the author Johann Hari, Chasing the Scream, and he has a new book, and this is something that I can give Jim Volendroff some credit for. When I worked for Jim, I can give him credit for a lot of things, but like a job. But when I first started working for Jim, he put this idea by me that he's like, I think the way to work with people in substance use and the answer to our substance use problem is about connection, and that's how we work ourselves out of this issue. And like I was saying, the author Johann Hari really who has a fabulous book about how this whole drug situation we got ourselves into and the way out of it, but really ascribes to that idea that the opposite of addiction is connection. And you think about services like the Recovery Cafe and other types of places that allow people to connect to community, to people, and I mean, goes back to like when I was in grad school and, Adlerian, searching for meaning and significance, right? And so, people just want to feel connected. They want to feel, significant. And, sometimes you want to go where people know your name, And so, just some elementary things like that. That's a nice segue into our next panel on supportive services too. So if you'll join me and give Dr. Grekin and David Newman a big round of applause, thank you. If we can have Noah, Michelle, and Lena come up.